Historically, severity of trigger finger was assessed by the use of a scale called the Quinell scale, which was published in the 1980s. The Quinell scale is a 5-point scale rated between 0 and 4, which describes increasing severity of trigger finger as the numbers rise. This was updated in the 1990s by a similar scale known as the Stages of Stenosing Tenosynovitis, or the SST scale, which was developed by Patel and Bassini as a 6-point scale ranging from 1 through 6. When comparing these scales, we can see that they are extremely similar. In reality, only the SST score 3 offers anything new in that it contains the words triggering, catching, and clicking, which is important since these are common characteristics of trigger finger. The inclusion of SST score 3 clarifies Quinell's score of 1, which is uneven movement, in that it divides it into the sensation of unevenness felt by the patient, which is SST 2, and the observation of unevenness seen by the therapist, which is SST 3. The SST scale is considered superior to the Quinell scale and is the current standard of measure for trigger finger severity. So let's take a brief look at what the grades on the SST look like. Grade 1 is normal movement of the finger where it is able to move smoothly through its full range of motion unhindered. Grade 2 of the SST scale is graded as uneven movement even though the unevenness is barely perceptible, but reported by this patient as being close to normal, which implies not normal. Grade 3 shows visible clicking, catching, triggering, but the movement is continuous and is not fully arrested at any point in its range of motion. In other words, there is no locking. In grade 4, we can see that the finger is arrested at a specific point in the range of motion and snaps into either the extended or the flexed position by continued contraction of the muscles controlling the affected tendons. In grade 5, we can see that the locking cannot be actively overcome and has to be unlocked using the other hand. In stage 6, here it is simulated as people with this level of severity always require surgery, and I never see people with this level of severity in my clinic. Although these measures are said to describe severity of trigger finger, it might be more accurate to describe them as scales of finger movement quality. To fully assess severity, we also need to measure two other key characteristics of trigger finger, which are pain and dysfunction. Pain can often be the worst symptom experienced by people with this condition regardless of grade, and so we need to have an effective method of measuring pain. There are two standard methods of measuring pain, both of which have similarities. The first of these is the Pain Numeric Rating Scale, or the PNRS, sometimes just referred to as the Numeric Rating Scale, or the NRS. This is simply a notional line divided into equal intervals between 0 and 10, with 0 representing no pain and 10 the worst pain imaginable. Respondents are asked which number best represents their pain. Similarly, the Visual Analog Scale, or the VAS, has a precisely drawn 100mm line with the left-hand side marked as no pain and the right-hand side marked as the worst pain imaginable. The patient is asked to mark on that line the level that best represents their perceived pain in relation to the two extremes. The score is established by measuring in millimeters from the no pain to the point where the mark has been made on the line. You'll notice that I use the word perceived here, and this is because it's almost impossible to measure actual pain as tolerances and thresholds vary between individuals. The millimeter is not a standard measure of pain, but it can be used as a proxy for pain perception. Both scales are used extensively in healthcare and are currently standard pain measurements in clinical situations, having demonstrated good psychometric adequacy of validity, reliability, and responsiveness. However, using the PNRS or the VAS only measures one of three parameters of pain, and that is intensity. The other parameters are frequency and duration. Intensity tells us how bad the pain is at any one time. As pain increases, the more the scale is recorded towards the right. For trigger finger, we already know that pain, together with stiffness and finger movement quality, is at its worst on waking, which for most is in the morning. We also know that symptoms associated with trigger finger usually ease as hand activity increases throughout the day. We also know that towards the end of the day, the affected finger stiffens and symptoms start to advance again. This suggests that in order to gain an overview of pain intensity of our trigger finger, we need to measure pain intensity at least 3 times a day, on waking, during peak activity, and before going to sleep. If your trigger is typical as opposed to atypical, you would expect variation of pain intensity throughout the day. However, intensity tells us about peak pain, but it doesn't tell us much about pain and how it endures. For that, we have to consider frequency and duration throughout the day. Frequency relates to the number of times in a measured time frame that pain is noticed. Typically for conditions like trigger finger, this would be the number of times the pain was noticed over a 24-hour period when awake. However, for other conditions, say such as migraine headache, frequency could be the number of times a migraine headache occurred in a month. Frequency can also be related to specifically identified activities which evoke pain either at the time of doing the activity or in a predictable time frame following the activity. This often precipitates the avoidance of these specific activities or the use of compensatory movements that can lead to unintended consequences, such as provoking new problems by causing unwanted biomechanical change. Duration is the length of time that symptoms persist over a specific episode. In trigger finger, frequency and intensity tend to be driven by activity, but duration can be variable and unpredictable. The interaction between frequency, duration, and intensity can be a marker of the seriousness of a condition. For example, if pain appears and doesn't go away for a whole day, it can be described as constant, meaning that it has a frequency of 1 and a duration of 24 hours. If we were to add to that an unchanging intensity of 8 or more on the PNRS, this would be something that required immediate medical attention, as this sort of pattern of pain can be indicative of a serious underlying cause. However, pain can be constant with variable intensity. This would be less concerning, but nonetheless should be investigated by a suitably qualified medical professional. Duration of pain is usually associated with chemical pain, which can be variable, slowly diminishing, and in the background, whereas peak pain intensity is usually associated with mechanical pain. So what does that mean? Mechanical pain is caused by distortion of tissues without causing damage to them. As I press my finger into my forearm, I feel a sensation of pressure, but I do not feel pain. But if I press hard into the forearm, this sensation of pressure would be converted into pain, which is produced by a sensory nerve response telling me that this pressure is either at or beyond the point at which my tissues are able to tolerate without causing damage. In other words, my nervous system is sending me a warning sign that if I persist with this action, damage may occur. When I remove the pressure from my forearm, the pain almost immediately abates, although there may be echoes of that exerted pressure in the form of a reddened area on the skin that will quickly subside. Under these circumstances, even though pain has been produced, no tissue damage will have been caused, as there is no long-lasting effect of the pressure, so we can conclude that the pain experienced was mainly, if not wholly, mechanical pain. However, if I change the parameters so that this time when I apply the pressure to my forearm more intensely and for a longer period, and in addition I reciprocate my finger for a few minutes, ignoring the warning signs sent to me by my nervous system, then this may result in damage to the underlying tissues by causing microbleeding or micro tears. Under these circumstances, damage to microscopic blood vessels called capillaries, sending blood leaking between the body's cells, which then leaches under the skin to appear as a bruise. This will evoke the body's natural response to injury or disease, which is called the wound healing cascade, that involves a series of chemical mediators, which are cells produced by the body to facilitate the process of healing, a large part of which is an inflammatory reaction that can persist for extended periods. In this example, mechanical pain is produced initially by distortion of the tissues, and the warning signals sent by my nervous system are ignored, resulting in damage that leads to chemical pain caused by the evocation of the inflammatory reaction. Similarly, in trigger finger, persistence of biomechanical dysfunction caused by the nodule passing through the A1 pulley, leading to snapping, triggering and catching in the early stages of the condition. Pain can be caused by mechanical reasons, in other words, distortion of the soft tissues. However, if this nodular irritation persists, inflammation of the synovial sheath covering the tendons will ensue, making pain endure beyond finger movement. This persistence of pain at rest is called chemical pain. It is likely that pain in trigger finger is caused by both mechanical and chemical pain, the former caused by bending and straightening of the finger, stimulating triggering or locking, causing peak pain, followed by a lower level enduring pain, which is produced by a reactive inflammation. The combination of these result in hand use avoidance, as not only does the use of the hand hurt, it also produces a prolongation of pain, can often result in night pain and sleep loss. This idea that pain can be both peak and enduring, or mechanical and chemical, leads us on to another method by which we can measure the level of severity of our trigger finger, and that is through the idea of irritability. To understand irritability, it's best to understand its extreme positions first. Take a look at this chart, which shows on the left side of the scale increasing activity that is known to provoke pain, and on the right hand side of the chart we have the consequential pain caused by the activity. At the low end of the spectrum, we could have a situation whereby a known pain provoking activity that is undertaken, but that a great deal of this activity is required before pain is experienced. Equally, once the activity has slightly reduced, the pain drops away very quickly. This set of circumstances is known as low irritability. Of course, at the other end of the spectrum, we could have a situation whereby a relatively small amount of aggravating activity produces a large surge in pain. And even when the activity is stopped, the pain persists and slowly abates. This situation is known as high irritability. The middle ground is when there is a direct relationship between the pain-evoking activity and the pain. Under these circumstances, as the activity increases, pain increases proportionately, and as the activity reduces, so does the pain. This situation would be known as moderate irritability. Of course, there is much variation along the spectrum, and in those spaces along the spectrum, there is some inevitable subjectivity in the way we might rate irritability. However, typically we describe these other levels as either moderate to high irritability or moderate to low irritability. Despite this subjectivity, it is nonetheless a very good way of rating the extent to which pain is a problem, both in general terms and in specific cases such as trigger finger. However, there is a final way for us to assess the extent to which pain is a problem when we have trigger finger, and this is through the measurement of sleep disturbance. Whether or not sleep is disturbed by pain is a binary measure. That is to say that there are two options, which are either yes, my sleep was disturbed by the pain, or no, my sleep was not disturbed by the pain. This is an excellent objective marker of pain levels in trigger finger. It will not be applicable to everyone, but for many, night pain in trigger finger is not uncommon and is one of the worst symptoms as it causes sleep deprivation. So who would have thought that so much could have been said about pain in general and pain in trigger finger specifically? Given that there is such a lot to remember, the best way to record it is using a diary. There are many kinds of diaries available, but in my book, How to Fix Your Own Trigger Finger, The Journey Begins, I give a framework for how a diary should be set up and utilised. The next thing we need to think about is measuring function. Considering the measurement of function is rather trickier. The reason for this is that in order to measure function effectively, we need to know what people are unable to do as a result of having trigger finger. In other words, before any treatment is applied, we need to know what it is that people are unable to do. For example, people may find it difficult to open jars or control a steering wheel or use a gear stick of a car. Or they may struggle to comb their hair or grip objects such as pans and kettles and the like. Many of these functional difficulties are specific to individuals, and so it's very difficult to provide a generic series or list of activities that they would find difficult to perform. The other thing that needs to be considered in terms of function is whether or not people adopt hand use avoidance strategies. That is to say that they find themselves only using the unaffected hand in order to avoid the use of the affected hand. They may also modify the way in which they use the affected hand to avoid triggering. Neither of these is advisable and, if possible, should be avoided. To assist with measurement of function, I have developed a rudimentary scale which is designed to assess the effect of a treatment strategy that I have created in 2 books. The first of these books, How to Fix Your Own Trigger Finger, The Journey Begins, which I've already mentioned, is where I've advised people to find out what it is that they are unable or unwilling to do with their affected hand. The second book is called the Manual Therapy Trigger Finger Protocol, The Natural Way to Treat Trigger Finger, where I demonstrate how other therapists should be able to reduce the effect of trigger finger in a single therapy session. After they have completed my suggested interventions aimed at dealing with trigger finger, I ask patients to complete this scale. In this way, people are able to triangulate between other main measurements that should be undertaken by people with trigger finger. To recap, these are the SST scale for normal movement, the pain scales, probably the PNRS for simplicity, the level of irritability, the presence or frequency of sleep disturbance, and the loss of function. All of this should be recorded in diary form and then, over a period of time, reviewed and judged as to whether or not the condition has improved, worsened, or remained the same in relation to the discussed parameters. Now, the main reason that measurement is undertaken is to establish a baseline. By that I mean there are a series of measurements which tell us about the state of our current condition. The second reason why we measure is to see whether or not our condition is getting better or worse, or just staying the same. It's possible that it may be getting worse in some parameters but not others. For example, pain may be reducing but function might be too. This is often a reflection of hand use avoidance or learned disuse. Another reason to measure is to assess the effect of any interventions that are performed either by yourself or others. We also measure so that we have a clear history of our condition, so that in the event that professional help is sought, we can accurately say how the condition has changed over a clearly defined time frame. This is helpful information for health professionals who will understand these measurements and their implications for treatment. So these are the things that we should measure when we treat trigger finger. If you'd like to see me demonstrate how I treat trigger finger, or find out about the mechanism of trigger finger, click these videos on the screen. I hope this video has been helpful. Thanks for watching.